Hi, everybody. Sorry for that few minutes of delay, but let's go ahead and get started. As is typical with a sharing care, I'm going to spend the first 20 to 30 minutes providing some information, and then there'll be time afterwards for questions and discussion. If while I'm in the middle of the presentation, you want to type some questions, Mary Ellen is here and can keep track of those. So today, actually, let me get to my first slide. We're actually going to talk a bit about after a hospital stay and helping families navigate some of the things that happen after a hospital stay around the discharge and going home. So first, I just wanted to introduce myself. I'm Dr. Nancy Burley. I'm the medical director at Tembo. I am family medicine trained and have been a family medicine physician for over 20 years. I spent about 15 years in practice, and then I spent, and then for about the past 5 years or so, I've been pretty much virtual and doing telemedicine. And I've been here at Tembo for the past few years, creating the clinical pieces that go along with Guide, and I'm, regularly working with the care navigators around any of the clinical issues that come up. So what we're going to talk a little bit today is just about dementia and the hospital experience. I think the diagnosis of dementia can make some things around hospitalizations a bit more difficult or more challenging. We'll talk a bit about discharge planning and about who goes home versus who goes to rehab and how those choices are made. We'll talk about some common challenges that people face after discharge. And then we'll talk a little bit about how to manage some of them. And I'll also talk about how we at Tembo and our care navigators can support our families, and also where people can find some support if they are not part of the Guide program. And then at the end, there'll be plenty of time for questions and discussion. So let's talk a little bit about dementia and just the hospital experience. For anybody in the hospital, it's an unfamiliar environment. There's lots of new faces, people coming in and out. There's changes to the routine, to the medications. It disrupts sleep. And so when you have somebody who has dementia, on top of all that, it can lead to increased confusion and some delirium, which I'll talk about in a second. People can get really anxious or agitated. And they can have difficulty understanding what's happening. Now, I'll say I think anybody can get those things when they're in the hospital, but it's especially challenging when there's also cognitive difficulties. So I do want to talk a little bit about delirium because it is something that can happen in hospitals. And if you are familiar with it, if it's ever happened, then you may know a lot about it, but you may not. Because delirium can often look like worsening of someone's confusion or dementia. So the thing about delirium is that it's a sudden change in behavior, it sort of comes and goes. So someone can be more or less confused than their baseline, or they can become more confused than their baseline, and then like the next day they're not as confused, and the following day they are more confused, and it can be jarring. Their sleep might be flipped, it might be disrupted. They could become more agitated or fearful or withdrawn. And the thing about delirium is it typically happens over hours to days. So the typical way that we'll see it is someone with dementia goes into the hospital, and within a day or two, they seem worse, like their dementia seems worse, and it can be very upsetting. But the reason it's different from dementia is that unlike dementia, which is, slow change, months to years, with delirium, you're going to see it happen sort of suddenly. And dementia is more of a steady decline, not this sort of like in and out one day to the next. Sleep can change with dementia, usually more gradually. And usually when you see behavior shifts, they're over time. Again, with delirium, it's a lot of back and forth kind of quickly. And with dementia, usually you're dealing with someone's baseline. You're not seeing a sudden change. So delirium is sudden and temporary, but recovery is uneven. And so improvement can take days to weeks. So when someone recovers from their delirium, they'll be back to their baseline where they were with their dementia. But it's important to note that it can take some time. And some people are going to go to rehab or are going to go home and still have a little bit of delirium that is going to look like worsening confusion. So let's talk a little bit about the family experience when someone's in the hospital. I think, I've been on both sides. There's a lot of new information. There's a lot of fast decisions to be made. There's lots of people coming in and out. It can be hard to know who's from what team. Medications are changed. And then there can be a lot of pressure, especially around that discharge, to make some fast decisions. And so for families, it can feel really rushed and overwhelming. So I want to talk a little bit about when discharges happen, how they're coordinated in the hospital. And they typically include a team that's going to be the medical team, because they're going to have a say on when the person is medically clear. There's going to be a case manager involved, probably some therapies like PT and OT, and of course the family should be involved. And the kinds of things that they're going to be thinking about is how strong the person is, how safe that person is. You can go into the hospital for something, like an infection, like a pneumonia, but you could get very weak from being in there. So those things also have to be considered, not just is the pneumonia better. What help are they going to need when they get out? What's safest? Is it going to be rehab? Is it going to be home? And also what options are available. But the one thing, and for those of you who've experienced this, this is the case, when it's time to get discharged, it kind of just happens really fast. So as soon as somebody is deemed medically stable to leave, you're like, the team comes in and says they're ready to go home. And the next thing you know, the case manager's in there like, okay, let's discuss, we're going to get them out, in a matter of hours. And, your head is spinning. And it can feel rushed, and it can feel like choices are limited and that you have to make decisions quickly. So my hope is to give you a little information just so that you have that and can know sort of what to look for. So in general, I'm making this kind of simplified. There's kind of two paths when someone's discharged from the hospital. And maybe there are a couple others, but these are the main ones. So some people leave the hospital and they go to rehab, or right there it says SNF or SNF. That stands for skilled nursing facility. So when you go to like a rehab, there's not only the rehab, but there are nurses there who are also providing some of the care. And the nurses are always there. There may not be a doctor there all the time, but there's always nurses. And other people are just going to go home. And some of them may go home with services. So they might go home with rehab services like PT or OT. They may even go home with nursing services. And now I want to talk a little bit about sort of what goes into the decision about what path somebody would take. So in general, the people who get discharged to go to rehab are usually, they're too weak to safely go home. And like I said, this isn't just about hospitalizations that might be about like a motor problem, right? So it's not just somebody who maybe, had a hip replaced or something like that. It might be somebody who was in the hospital for a medical reason, and over time from lying in bed, they've gotten very weak and now they can't safely go home. They might need physical or occupational therapy to do a lot of very basic things. And when I say walk, transfer, or dress, I'm talking about at a baseline. So if there's somebody who has dementia who doesn't dress themselves, I don't think the plan is going to be to have them dress themselves, but at least they need to be able to walk and transfer safely. If they need nursing care, like for wounds or for IV medications or close monitoring, they may end up in a rehab. If the home is just not safe, for example, sometimes people are sent to rehab if there's stairs in the home that they have to take and they can't do stairs yet. And then I put this, families need time to prepare for care at home. I don't think that's a singular reason, but it may go into some of the decision making. And I think it's important to know that the length of stay in a rehab varies. Some people just go in for a few days, some people go for weeks. So let's talk about some of the strengths versus the realities of going to rehab. So some of the strengths are that you're going to get very intense PT, OT. There's going to be nursing oversight. The medication is going to be monitored, and it's a structured environment. But some of the realities are it's an unfamiliar environment. And again, the same things apply as in a hospital. It can cause more confusion. If you have delirium, it could make it last a bit longer. The therapy can be tiring. Recovery is going to be uneven. Some days are going to be better than others. And it's really a short stay focused on safety, so not necessarily full recovery. So let's say you have somebody who's gotten weak and they have stairs in their home. And in order for them to go home, they need to climb stairs. Well, the goal might be to get them to climb stairs, but they still have more recovery to go. So if your loved one is going to be going to a rehab, you might just be told they're going to rehab and this is where they're going. This is what we have. Sometimes they might say, we have 2 different rehabs. Do you have experience with either one? And so, what are the kinds of things that you might want to look for? What are the things you could sort of ask, the location or even the case manager? Like you might, be able to get a sense from a brochure from the case manager, is this a clean, like a calm environment? Are the staff patient? Do they have experience with memory problems? You may be able to find out if they're willing to answer your questions and understand that they have like a clear therapy plan. Now, it's possible that you're just given one option and there really isn't an option to sort of choose between, but these might be some of the things you would think of. Questions that you might want to ask. You might want to know how often therapy is happening. Might be happening once a day, might be happening twice a day. Who's managing the medications? It's maybe a nurse, but it might be a med tech. That may or may not matter. You may want to know how they handle confusion and agitation, how your family is going to be updated, or how you're going to know that they're ready to go home. So those are just some things that you might think about asking. If your loved one's going to go to rehab, I think it's helpful to sort of transition them. They might worry that they're not going to get home, letting them know they're just going to get stronger and they're eventually going to go home, bringing them familiar items from home. The other thing too is, since a lot of it's therapy, making sure they have nice, comfortable clothes and like sturdy shoes. And then if you can, visit regularly. But I think it's really important, to really just try to stress that this is just to get them stronger. So let's shift a little bit and talk about people who get discharged home. So they're likely to get discharged home if they can move safely. Like I said, if they can manage the stairs and the other things in their house. If therapy can be done after discharge, sometimes that might be done at home. They may not need as intense therapy because they're not going to be getting it once or twice a day. They don't need ongoing nursing care that's constant. Sometimes people are sent home with some nursing services, but this is like they don't need it 24/7. The home setup is deemed to be safe, and the family and caregivers have some time to sort of prepare for this. And going home, you may also need support, and it's okay to ask for that. So some of the, strengths or the positives of going home is it's a familiar environment. If there is confusion or delirium, it is probably going to get better once somebody is home and in their familiar surroundings. It might be comfortable and you have their routine and the family's, the family is there. But on the other side, the care needs are probably going to temporarily increase, and that can be difficult for families and caregivers. Fall risks may require closer attention. Medication changes need to be tracked. And, the recovery is really going to depend on what's available to support people. And so when someone's going home, they might be weaker or more confused. They may need more help at first. Medications might be different, and the recovery can take some time. But I do think it's important to know that there are things you can ask for. Like you can and should ask for a very clear medication list. You can and should ask for any home health that your loved one might be qualified for and can get if it's needed. A plan for follow-up visits. Instructions on like what to watch for. What are the things you want to, need to do something about. And then also getting teaching on how to help safely. For example, let's say your loved one is now gets a little bit of assistance getting up. Well, have somebody show you how to do that safely. So I want to talk a little bit about why the time after discharge is so important. And in this case, I'm talking about discharge from the hospital to home, or once they're done with rehab and they're going home. And that's because in the first like week to month that someone goes home, there's actually an increased risk of getting hospitalized again. And part of it is because people are still recovering. Their medications might change. The care might be harder at home than might even be expected, even by the staff, and maybe more support's needed. There can be confusion and weakness, and hopefully it's going to get better, but it can get worse. And sometimes it can be really hard to have follow-up appointments, especially when you're managing taking care of somebody. So there are some things that can sort of lead to some increased risk, and I just want to talk a little bit about them and talk a little bit through them. So medication mix-ups, and I'll talk a bit about that in the next slide. There also can be changes to appetite, and people are not eating or drinking enough. It might feel like they just got home from the hospital, they really need to eat and drink, but they may just not want to, and that can lead to some dehydration. Again, there might be an increased fall risk at home. They might have trouble walking, they might fall. We talked a little bit about the confusion, behavior changes, and also it is more stress on the family and the caregiver. There's just more need. So I want to talk a little bit about medication changes, because this, I think, is a big one. And for anyone who's ever been in the hospital or had a loved one in the hospital, then you know that like you get to the hospital and first they don't have your medication. They don't have that formulary. So they change that. And then maybe they can't give it at a certain time, so they give it at another time. And suddenly the whole medication sort of regimen is so different. And then you leave and maybe they've switched one or stopped one. And there's a lot going on. And so, when you're leaving, you should be asking, what's new, what's stopped, what's changed. And this is whether you're leaving the hospital or you're leaving rehab. Understand what each medication's for, confirm when and how it should be taken, and either write it down or get a list or take a picture of it. Just to really try to understand what the changes are. And then you want to watch, all of these things are things that could happen anyway, but if they're suddenly more sedated or there's sudden behavior changes that, are different from when they were in the hospital, they're more dizzy, they're falling, they're refusing to eat or drink, these would be things to look out for that could be related to medication changes. But one of the most important things is also going to be to make sure that you know what the current medication list is. I also want to talk about following up with your primary care physician and why it's so important to do that sort of early on, even though it can be a bit of a struggle. And you want to try and schedule a visit within a week or two of discharge, either from the hospital or rehab. In different offices might do it different ways. Some offices might offer you a telehealth visit. Some may have the nurse call to get some of this information, but they should, be reviewing the medications again, making sure that they agree with all the changes that were made, and check how the person is doing, and try and catch new problems early and help plan the next steps. And I think this is another piece that really allows you to prevent some of these complications, is really just sort of making sure that you're connecting with the care team and that the care team knows what's going on and that you're getting all of your questions asked. So other things that you can do to try and reduce the risk at home of these, complications or rehospitalizations is, keep the routines predictable, same wake time, bedtime, meal time. That's going to really help, especially if people are a little more confused when they get home. If people's appetites have changed, try offering small meals and small amounts of fluid throughout the day rather than expecting big meals. You want to just make sure that there's clear paths, and that if there are mobility aids like a walker or a cane that they're to use, that they do get used consistently. I know that can be a struggle sometimes, but in this time after a hospitalization, it's probably really important that they have that extra assistance. Keep things, recovery is going to take time. It's going to, so it may be a slow pace. If you can schedule those follow-ups early, that's going to be helpful. And, as I said, if there's a way to do it that doesn't involve having to bring somebody who's recovering into the office, I think that's probably going to be preferred. And then, ask for help. If you're already at a baseline taking care of somebody, this is going to add a lot more to your plate. And so this type of recovery and care is really going to be a team effort. So if there's family or friends around that you can ask for help, it's probably a time to do it. And, of course, I'll get to it in a minute, but some of the things that Tembo can do. So what do you do if something changes at home? Say you're home, you're going along and now something's happening. Maybe there's a sudden change in confusion or agitation that hadn't been there before. They're refusing food or fluids. They're falling. There's medication issues. You're confused. There's mistakes being made, or just the person just doesn't seem right. The first thing to do is just to kind of take a pause and just, check medications, check hydration, ensure that everything is safe, and then, call your care team. So if you're noticing something, this is a time to call the team and say, something's not right. Even, you could call your PCP. If you have a care navigator, you could call them and say something's not right. They could help you decide if it's time to call the primary care doctor, or the clinical team could weigh in, but definitely reach out, because you're not alone. And, there are some struggles that happen. So I do want to talk a little bit about how Tembo does support our families throughout these transitions. Sometimes the care navigator will say, oh, I talked to them, but, so-and-so's in the hospital, they didn't need anything. And that may be, but I also, everyone should know that in the hospital, that is a fine time to ask your care navigator for help understanding what's happening, clarifying medical information. They can always bring it to the clinical team and we can try to help you understand. If there's questions about decisions about where to be discharged, or is it rehab, is it home, are there a couple of rehabs and you need some information about them, and then sort of just preparing you for what happens after discharge. And so if any of that support is helpful while your loved one's in the hospital, you should absolutely lean into that support. And, often your care navigator is going to know you and your family pretty well. So that also helps. During discharge and transition, we can help you by reviewing discharge plans together so you understand, so you know what questions to ask, coordinate next steps and follow-up. Let's say it's a discharge from rehab and your loved one still needs some PT and you're not clear how that's going to happen at home. This is something that the care navigator can help either by, looking over the discharge information, or if it's a matter of needing to help you connect with somebody, do that. And then just staying connected as the needs change. And then, once you're home, again, I keep talking about reviewing medications, but I feel like you can't really review them or ask questions about them enough, especially if there have been changes. They can help you monitor for any changes or concerns. They can sort of help, like I said, help you figure out when it's time to give a call to your primary care doctor. If as routines might be changing, they can sort of help with that. And just also coordinate care and services. So in addition to respite benefits, if you have home health, and a nurse coming in and you need some help coordinating some of that, that's a place where the care navigator can step in. And I know that not everybody on here is part of the guide program. And whether you are or not, there's some other ways to find support. You could always talk to your primary care doctor or the practice nurse. Hospital social worker or case manager may be able to help, especially with coordination. If you have home health coming in, often there's a nurse who kind of oversees it all, and they could be a good point person. You also may have some area agencies on aging that can help, as well as dementia and caregiver support organizations or community-based organizations. So really leaning into whatever is available to you to get you the help that you need. So I'll pause there and open it up for questions. We have a comment here that the challenge of finding a rehab bed was very stressful. It took a few days, but luckily the hospital was willing to keep an extra 2 days until our first choice opened up. Not sure if this is common. I do think, unfortunately, it's common. And I guess you were probably sort of fortunate that they were able to keep your loved one there while the first choice opened. I do think sometimes not everybody can get their first choice, and that can be tough. But that may be why you want to really ask some of those questions. And certainly you should never sort of settle if you don't feel that your loved one's going to be safe or well cared for. I think sometimes we use some of the same words, home health. And so there's a couple of different sort of types of agencies. If you or if your loved one needs some sort of nursing care, if they have a reason for a nurse to come out to the home, that's typically a home health agency, and that's when like a nurse will come. This is typically like after a hospitalization, maybe there's a wound that needs to get changed, the bandage needs to get changed, or maybe they need physical therapy, and an order has been written by a physician and the insurance will cover it, then they will get that type of service. And it's usually limited for a couple of weeks. But the other type is sometimes we talk about it here at Tembo, home health agencies that do more of that respite, which is a bit more of just sort of companion care. And so they may not be as skilled. They don't need an order, but most of that is either out of pocket or through the guide monies that they give for a respite. Yeah. The other thing about home-based services is that the person who is getting them has to be deemed homebound. So sometimes people will be referred for physical therapy or occupational therapy, and they want to, have the person have that at home. But if they're not technically homebound and you can't make a case to the insurance that it actually needs to happen at home, then it might be hard to get that as a home service. And somebody asked, oh, yeah. So now we're talking about hydration. Mom drank better out of a straw while in the hospital, so we started using a straw and that helped. Yeah, that is a great suggestion. I also think it's helpful to offer small amounts rather than, sort of handing a big, cup or, that can be overwhelming. And Mary Ellen, I don't know if you have any other, I know this is something that comes up quite frequently.
Yeah, and I did see Gary asked about how to get the person to drink more water as well. Definitely the small cups and lightweight, maybe with a handle or straw. And you can not just have water, but maybe put a splash of juice in it, like herbal teas or flavored seltzer, make it more appealing. Warm things are also a good way to get fluids and don't seem like a full glass of water, like tea or broth. And also to become hydrated, soups or smoothies, puddings, popsicles, and Jello. They're great for hydration as well.
The other thing I know that some of the care navigators have spoken about is something called jelly drops.
Yes, yeah.
Yeah, which is sort of like it's sugar-free, and it is almost like a gummy kind of thing that will increase hydration. So that could be something worth looking into. All right, and then we have Jamie from Right at Home. And she said, as a home care agency owner and partner with Tembo Health here in New York, what can we do to introduce and share the value of Tembo care navigators working with discharge planners in planning for discharge back to the community with home health and home care? Or are you actively reaching out to discharge planners to let them know what you can do to help them in planning for optimal care at home? Both. Yeah, so for people who are enrolled in Guide, the care navigators are able to do whatever they can with the information they have. So if we know that there is, that they're in the hospital especially if the family wants them to reach out to the discharge planner, then I think that that is a role that we're happy to help with. But I think more times than not, we don't always know that it's happening. And this part of the reason for this was to really let people know that they can and should use us as a resource. And then in terms of people who might benefit from Guide, and, and might, maybe as they're coming out of, and someone is discharge planning, I think, that's always a place where we want to let people know about our services. And, in some health systems, we've been able to do that. And in others, we may not know the right people to connect with. So if there's anyone in your area that you feel like we should be speaking with, I think that would certainly be helpful, because often Tembo can be part of that discharge planning and the Guide program.
There was also a question that came in through the Q&A. And it says, will the Tembo Care Coordinator reach out to clients regularly to family post-hospitalization? And that I think that came from Clarence at Home Helpers.
Yeah. So I would say, and Marilyn, maybe as long as the care navigators know that this is happening, then yes, that's usually part of the plan. But sometimes it can be, if we don't hear from the family or we don't know that the hospitalization has happened, we might get something through our EHR, but we might not. So, even a quick text, to your care navigator, like, hey, so-and-so went to the hospital, that allows the care navigator to say like, okay, let me make sure I'm checking in with them. And certainly if there's, people that we're partnered with and we have families in common, and it makes sense, to just give us a heads up, that would be another way that we could help to coordinate that care. And I'll also take a minute just to remind people that we do these on the first Thursday of the month.